So let's come to OCT abnormalities in various retinal disorders and what is the significance of those. So it's quite evident to you that OCT is the bedrock on which management of retinal disorders is anchored for diagnosis and also for follow-up. And that's how it's important for us for virtually every retinal condition. So the abnormalities that we see can help us in making the diagnosis, the treatment, the follow-up, and the prognostication. Let's start off with the condition straight away. OCT in macular degeneration, age-related macular degeneration. There are two aspects to it, the drusen and the geographic atrophy in dry ARMD, and the exudative changes, which could be either type 1, type 2, or type 3, or the occult CNVs, classic CNVs, or the retinal angiomatous proliferations. Now, what you see over here, the undulations of this RPE, these are basically because of drusen, and these are a sign of dry ARMD. No active, if there's no fluid over there, this is not active CNVM at the moment. So it just needs to be followed regularly, nothing else needs to be done. Now you see what happened over a period of time. This intact ELM, external limiting membrane, ISOS junction, the RPE layers, now they've been disrupted over here. The external limiting membrane has disrupted, the ISOS junction and the corresponding outer segment, inner segments are disrupted, and the RPE is also disrupted. So basically, as a result of that, what happens? The outer nuclear layer has collapsed. So this is an outer nuclear atrophy, basically has occurred, and this is nascent geographic atrophy. This is a dry ARMD. On the other hand, here what you have CNVM because of ARMD. The type 1s are under the RP. You see a retinal pigment epithelial detachment over here. Of course, there's also subretinal fluid over here, but the lesion, the basic lesion is under the RPE over here. In the type 2 lesions, you have the lesion above the retina, above the RPE. So this is a classic lesion, also now called type 2 CNVMs. Then comes type 3 CNVMs. What is happening here? You see in the retinal substance, there is a lesion which is growing into the under the RPE and then causing an RPE detachment. So this is a type 3 CNVM, a very small retinal angiomatous proliferation is seen over here in this lesion, and it's just about breaking the RPE over here. So this is the various types of CNVM, and you can also help to prognosticate, you follow up, as you will see here. Now, this was a type 2 CNVM. This patient had this old OCT patient got PDT, and you can see how with the treatment, this CNVM has vanished. There's only a little more intensification of the RPE level. That means there's probably a little RPE hypertrophy occurring there, but the entire lesion has vanished. So you can use it for follow-up of your patients of classic CNVM. Similarly, you see over here, this is an occult CNVM. There's an RPE detachment in subretinal fluid. And following treatment, the RPE detachment has become much more shallower and the subretinal fluid has disappeared. And then over time, you'll see intraretinal cystic cavities have come. These intraretinal cystic cavities are a sign of recurrence. The RPE detachment is much less, but there is a recurrence which has happened, indicating that the patient now needs treatment. Intraretinal fluid is almost always treated. So you can make your initial diagnosis, you can follow up, and then you can pick up the recurrences also. This is a patient who had a serous RPE detachment. You see, it's clear RPE detachment, very bullous, was followed up, and then you can see at this time the fovea is normal. This is extrafoveal. And then over a period of time, what do you see over here? There's a rip here. This had been treated before, but this is a rip over here. You see the RPE is coming up to this level, and then there's a discontinuity, and there's subretinal fluid. So this is a sign of a RPE rip. Incidentally, even if an RPE rip occurs, the patient would still need to be treated for this disease process. Now you have a patient, and he has some cystic cavities or so-called cystic cavities. But look carefully, this is not a cyst because of activity. This is an outer retinal tubulation. This is basically the RPE forms this kind of a wheel around, and there's a central area of fluid. This is a sign of a severe degenerative change. No, not an indication for treatment. So this is the other important thing that you need to manage. Now let's need to know about. Now let's come to central serous chorioretinopathy. Again, you have a neurosensory detachment over here, but you have a small RPE detachment from where the leakage are happening. So you know that this is in the acute stage. Many of them will conservatively improve. Sometimes they will need to be treated. Now you come to the chronic CSR. This is chronic central serous chorioretinopathy. And what do you see? You see a brush border sign over here. You see these irregularities at the level of the outer segments. So these are waste products accumulation at the level of the photoreceptor outer segments on the outer surface of the retina. So this is a sign of chronicity. Now let's come to other things. What else can help you to make a diagnosis of CSIR? If you do enhanced depth imaging, you can pick up that the choroid is very thickened. You can see that the choroid is very thickened in this patient, and a presence of thickened choroid with fluid is a sign that you're dealing with a central serous retinopathy. But sometimes you can have this central serous retinopathy, and yet this is not CSR. This is a dome-shaped maculopathy. This is a myopic patient, and if you see this kind of dome kind of appearance, it's not there in all the quadrants. It may be there in one quadrant, may not be there in the other quadrant, as in this patient. In the vertical quadrant, it's not there. In the horizontal quadrant, you see there's this huge dome. This is a dome-shaped maculopathy and is not the same thing as, this is not a CNVM, and this is not a CSR either. Polypoidal choroidal vasculopathy, I said, is a variant of ARMD. And here, if you have a patient who has excessive exudation of a lot of hemorrhages, when you see a picture that looks like this, that means there are peaked PEDs, high PEDs. This is called a tomahawk sign, actually. This is a because of the high PED with shallow undulating PED adjacent to it. And if you look carefully at this shallow adjacent PED, you see there's another layer within it, which is called the double layer sign. This is suggestive of a branching vascular network within that lesion. And so this picture is characteristic of a PCV, a polypoidal choroidal vasculopathy. At the same time, sometimes there are some mimics, like what you see over here. This looks like a type 2 CNVM, but actually this is amorphous material. If you do an angiogram, you find that it's not increasing in hyperfluorescence. If you see the autofluorescence, it shows as a autofluorescent area. And that is your clue that you're dealing with adult vitelliform degeneration. This is not to be treated, doesn't need any require any treatment. And this, on the other hand, is a patient who has, if you see the fluorescein angiogram, it looks like a late leakage from an unknown source. But this, if you see carefully at the OCT, this space over here, there is no abnormality in the RPE. There is no lesion at the level of the RPE. This is actually a juxtafoveal telangiectasia, and this is degenerative fluid. In this case, there is also a small epiretinal membrane that has happened, but otherwise this doesn't need any. We don't treat this unless these patients develop a choroidal neovascularization. Incidentally, we have a lot of time, so that is why I have progressed a little slowly. We can complete this lecture. So I'm just going to take a little more time. So let's see other things which can happen. Now, a blunting of the foveal contour in this OCT is because of a membrane here, epiretinal membrane, which Purnima also showed you. And this, if it is causing vision loss, is you consider for treatment. Now you see this, there was a complete discontinuity. This is a macular hole, and this is post-treatment. You find the macular hole has resolved. Now, what can help you to decide whether this macular hole surgery will be successful? The hole form factor, that means you see the walls, the side walls, and you do the ratio of the side walls to the base. And if this is around 0.9 or more, the chances are that the hole will settle. Of course, I think in Narayan Netralaya, they've done many other parameters and to analyze the prognosis of the macular hole surgery, but this is a basic way of judging. If there's too much distance between the holes, between the two parts of the two walls of the hole, then the chance of success go down. The bigger the hole, the lesser the success rates. Now, sometimes this is what is very important. Now we come to a very important thing for cataract surgeons. Macular hole was one. Supposing you have a patient who's not improved following surgery, please do the OCT. You hope you don't have a macular hole there, which is responsible. Or you may have cystoid macular edema. If you have cystoid macular edema, this is going to respond very well to medical treatment. And so it's important to be able to diagnose it and treat it properly with NSAIDs and steroids if required. Now we come to vascular disorders, the last group of disorders today. If you have, which you can have arterial and venous disorders. Let's see what do they look like. So this is a patient who has a CRO. And what does the CRO show up in the OCT like? In the OCT, what you get is an opacification of the inner retinal layers. You see this? The inner retinal layers are opacified. The outer retinal layers are spared. This is a classic process of a CRO. Or if it was a BRAO, it will be only in one side, maybe the superior or the inferior, and not the entire retina. With time, once it heals, once it starts resolving, the patient, this opacification will go away, but some retinal thinning will be left at the end. So this is how you make a diagnosis. Now, the other important thing is CRVO. If you have CRVO, on the other hand, the patient has macular edema, increased retinal thickness, there could be subretinal fluid, intraretinal cystic cavities, but they are usually confined to the macular area. And you can see, you can use this also for assessing response. Following treatment became better, then got a recurrence, again was treated, and you can see how he is responding to pharmacotherapy. So it's very important to use OCT for following up your patients after you made your initial diagnosis. On the other hand, if this was a BRVO, what would be the difference? BRVO, you can actually, if you see the vertical scan, either the superior retina or the inferior retina will show increased thickness and increased retinal and intraretinal cystic spaces, maybe even some hyperreflective dots, but they are not going to cross the midline, and that is pathognomonic. When you have edema localized to one side, not crossing over to the midline at all, you know you're dealing with a BRVO, most probably. And again, you use the OCT for seeing whether the patient is responding. As long as he's responding, you treat. Once it becomes okay, you don't need to treat any further. So you can also use this for following up your patients. In diabetic macular edema, again, you use it for diagnosis and for management. For example, you see this patient, there is an epiretinal membrane, there is edema over here, and there is over here in the lower slide, you have a vitreomacular traction. In both, the fluorescein angiographic picture may give you a diffuse diabetic macular edema, but this requires surgery when there is traction. And if it's only a membrane with associated edema, it needs medical treatment. And you'll only treat the ERM if you believe this is the cause of the edema. In maculopathy, in diabetic maculopathy, there are also certain important biomarkers like trill, subretinal fluid, intraretinal changes, the outer limiting membrane, and the photoreceptor layer integrity, and hyperreflective dots. So let's see this. See, in general, you have a patient who's got edema, a little bit of neurosensory detachment, you're giving injections, for example, following up, and you can see now that the subretinal fluid is gone, intraretinal cystic cavity is gone. If the vision is okay, you know you don't need to give any more treatment. So you can follow up your patients with OCT very, very accurately. In some patients, you may find the vision is not improving, or you want to prognosticate. You see, you look at this small layer above, or on the other side, on both sides, you can see all the layers, you can distinguish them. But in this small area, there is an inability to distinguish the boundaries of the ganglion cell layer and the inner plexiform layer and the inner nuclear layers. Now, when you reach this, when you see this point, this is what we call drill. This is disorganization of the retinal inner layers. And this is a prognostic indicator that this patient may not get much vision improvement, even following intervention. We normally look for this in the central 1,000 to 3,000 micron and look for the extent of these changes to decide what is going on. The other important thing is subretinal fluid, what you see over here. This is a biomarker for better visual outcome. Patients who have subretinal fluid generally seem to do better following treatment. Absence of hyperreflective spots. What you see over here, these small dot-like things, these are hyperreflective spots. And to be sure, you must have a color photograph showing that there are no hard exudates in that region. Hard exudates are not the same thing as subretinal. Hard exudates show up also on the OCT, but hyperreflective spots don't show up in the color photograph. So you know you're dealing with hyperreflective spots, and their absence is a good prognostic indicator. And we will also discuss about the ISOS junction. Now, presence of subretinal fluid, absence of hyperreflective spots, and in a complete integrity of the ISOS junction, these are all predictive of better outcome following treatment. And there's a study which was done in dexamethasone implants, which showed that this was good. And the predictive value did not vary whether they were treatment naive DME patients, but the vision response was better than in refractive eyes. Now here you see two eyes, both have a lot of cystic cavities, but in this one, you have an intact ISOS junction and intact and partly intact external limiting membrane. Visual prognosis was good. Here they were all disrupted and the patient did not do well. This is a patient who had an epiretinal membrane, also a vitreoschitic membrane. You can even see those layers of vitreocytes in the OCT. And in this patient, following a vitreoretinal surgery, you can see there was a good recovery. And this was one-eyed patient who did well following surgery. So OCT can help you to see how your patient is doing, predict, as well as tell you when more treatment is needed. So, ladies and gentlemen, to conclude, OCT is the workhorse for diagnosis of retinal disorders. It's non-invasive, sensitive, provides detailed insights into the pathoanatomic changes occurring in the retinal microarchitecture, and has really revolutionized the management of retinal disorders. Thank you very much for your attention.